come in from the waiting room, and we'll be starting in just a moment. We should be set very shortly. Janice, could you, well, before we get started, let me just provide folks who are with us today a little bit of introduction about our speaker and introduce you to Dr. Hannah Galvin. Dr. Galvin is a clinical informatics thought leader nationwide, recognized for her expertise in the segmentation of data to protect patient privacy and to promote interoperability. Hannah and I were just talking earlier about how interoperability and privacy seem at times to be at odds with each other, but that needn't be the case. As a matter of fact, interoperability and the move to an API-based health data economy enables a degree of control over privacy that was otherwise not available. Dr. Galvin guides major professional societies and health IT vendors regarding complex issues of patient agency to support the evolving technology-enabled continuum of care and to preserve the privacy that those patients are entitled to. Dr. Galvin advised the Office of the National Coordinator for Health Information Technology, or ONC as we all know it, in relation to the recent 21st Century Cures Act on interoperability, information blocking, and the ONC Health IT Certification Program. Dr. Galvin is a co-founder and co-lead of the Protecting Privacy to Promote Interoperability, or PP2PI. We will be talking more about that as we progress during the day. It's a national expert work group supported by the Health Information Management Systems Society, HIMSS, integrating the Healthcare Enterprise USA, and the Drummond Group. Currently, Dr. Galvin serves as the Chief Medical Information Officer for Cambridge Health Alliance, an innovative academic public health system dedicated to providing care for all patients in need throughout the Boston North region. Dr. Galvin is also an assistant professor of medicine at Tufts University School of Medicine. As an experienced primary care pediatrician and a hospitalist with specialization in child abuse medicine, her clinical work focuses on vulnerable populations, including at-risk adolescents. Dr. Galvin is dual certified in clinical informatics and pediatrics. She trained at Boston Children's Hospital, and graduated from Harvard Medical School and Wellesley College. Dr. Galvin, thank you for joining us today.
Thanks for having me, Denny.
Delighted to have you. Perhaps we can move to the next slide, and we'll provide a little bit of intro and then turn it over directly to you, Dr. Galvin. For today's webinar, please feel free to play along on social media using any of the following on Twitter. You can see the MHDC Twitter handle, Dr. Galvin's handle, her organization, Cambridge Health Alliance, and we have the following event hashtags, including MHDC Galvin Consent and Mass Health Data. Some rules of the road. All attendees will be muted during the presentation. Please enter your questions in chat or save them for the end of the presentation when we'll take all your questions and answer them directly. We want to move through, given the number of folks who have joined us today, without interrupting the presentation over its course. We are recording today's interview. For those of you who come online, you've seen the Zoom blurb that tells you that that's the case, and we will make this video available to all members of the MHDC, all members of MHDC within 3 business days. Please take a moment to complete our poll at the end of today's meeting, also so we can improve our interviews, webinars, and other events we provide to the community. Next page, please. Briefly, who is MHD? Some of you may know us well, some of you may not, but we are the oldest organization of our kind, if not the only organization of our kind in the country. We convene all members of the health community, payers, providers, associations, government, vendors, thought leaders, patients, anyone with a focus on health data. And we do this in an independent and unbiased way. We have expertise in health data standards and regulations. We are very locally focused. We were chartered in 1978 by the state of Massachusetts and a number of healthcare providers and health plans, but our influence is nationwide in terms of our knowledge and what we can bring to the table on some of the data issues that are being keenly felt by payers and providers and patients today. We consider ourselves to be inventive, innovative, and we like to incubate services that provide value to the community without sweeping all the money off the table, which is often the case when organizations require complex technology solutions. We look for solutions that can reduce those costs and enable the free flow of information across that triangle of patients, providers, and payers. Next slide. Briefly, what do? We have a data governance collaborative. This is our interoperability hub. We collaborate for a purpose to advance data quality and standardization. We offer exchange services. We merged with the New England Healthcare Exchange Network, NEHN, and now provide a community-governed health data exchange between payers and providers, and a platform on which we will test advanced exchange methodologies, including but not restricted to electronic or real-time digital prior authorization, as well as other leading technologies or leading services where our exchange services can act as a test kitchen, taking the cookbooks from some of the leading accelerators and building and prototyping what might be possible. We offer analytics services for hospitals and health systems to work on both patient care as well as business analytics. We offer our community the Vantage Point series, which is a series of interviews with thought leaders who've had a major influence on the healthcare landscape, the healthcare data landscape, as we know. We've talked to Mickey Tripathi, we've talked to John Glasser, we've talked to Mark Gans from Cambia Health Solutions, and we'll be talking with Alexandra Drain in just a month or two. So we try to do the Vantage Point series in such a way as to bring, enable us to step away from the trees that we look at every day and get a chance to look at the forest for a change. We have a forum, an expert dialogue among industry leaders on new and emerging trends and regulations. This is really targeted to health plan, health system, public health, chief information officers, and information technology executives so that they can get as close to understanding what's happening in the state, the region, and in the industry that will be helpful in terms of getting their particular charges completed. And lastly, and today is an example of this, we provide webinars on what we consider to be the most important health data topics and other subjects that are of greatest interest to our audience. So thank you for that, allowing me that introduction, and we'll move now to the presentation. And Dr. Gavin, thank you for joining us, and I'll turn it over to you.
Thanks, Denny. I think I have the presentation up here. So let me know if you guys can't see it.
We do see it.
Right?
We're good.
Fantastic. So thank you for that kind introduction, Denny. And as you said, we'll be talking today about the granular segmentation of data, specifically sensitive data, and we'll talk about what that means in order to protect patient privacy and to promote interoperability. And as you mentioned, those things have often been thought to be at odds with one another. And I'm going to hopefully show today how actually protecting privacy will actually forward and further our efforts to promote interoperability and especially to do that in an equitable manner. So I don't have any conflicts to disclose. And as you mentioned, I am working with, I'm the co-founder and co-lead of this Protecting Privacy to Promote Interoperability work group that is supported by HIMSS and IHG USA and the Drummond Group, a test lab and certification body. We were formed in 2018 and formalized and chartered last year in 2020. This is a multidisciplinary work group of national industry experts. We have over 160 members at this point from healthcare provider organizations and institutions and professional societies like the AMA, AAP, American College of Physicians, ACOG, standards development organizations like HL7. We're working very closely alongside some of the standards development work that's going on within HL7, which I'll talk about in a little while. The major health IT vendors, Epic's at the table, Cerner's at the table, Allscripts, all coming together to work on and try to tackle this challenge. The HIEs and interoperability frameworks, payers are at the table. The government is at the table. ONC has been part of this group since the beginning and has been continually promoting it. We have met regularly with ONC and more recently with ONC senior leadership, including the national coordinator himself, Mickey, and his senior leaders to try to continue to promote this work and align with ONC's roadmap around it. Other contractors, government and non-government contractors. We have experts on privacy law and ethics, as well as patient advocates informing all of the work that we do as well. So let's start with a couple of clinical case examples to talk about why this work is so important. As a pediatrician, this is often thought to be needed due to concerning sensitive data around adolescents, but it's really not an adolescent issue. It's not an issue related to just those with specific types of sensitive data like substance use disorder. It's an issue that really affects all of us or could affect all of us at some point during our life cycle. So I like to start with this case example. This is Paul. He's a 72-year-old retired teacher. He comes in for an annual physical and he has a history of alcoholism. He's relapsed over the past decade since his son was killed in Afghanistan. And, a depression was diagnosed, an underlying depression, and he's improved on medication. He was prescribed a serotonin reuptake inhibitor, and he was prescribed counseling, and he's improved. And this is like many of us, like many of our family members, and he's doing well at this point. He has some medical problems as well. He has hypertension, high blood pressure. He has atrial fibrillation, which is a heart arrhythmia that is pretty stable. He has gout. He has had some mini strokes or transient ischemic attacks in the past couple of years, which are treated with a medication, or he's on an anticoagulant medication to prevent those from happening in the future. He comes in today with his wife, Donna, who is a 74-year-old retired accountant, and she is designated as his healthcare power of attorney or his healthcare proxy in waiting, which means that she's not making his decisions for him yet, but if anything should happen where he loses the capacity to make decisions for himself, she would be the one to make decisions for him. So today on his visit, as you're talking to him and you're talking to Donna, she says, hey, Paul has been having some difficulty with his short-term memory, including getting to his medical appointments. And this is of particular concern because, as I mentioned, Paul is on this anticoagulant, which is called warfarin, which requires him to get regular checks of a blood test called an INR to monitor how well the warfarin is working. And so he has to go to regular lab checks, regular lab visits for this. And she says he's having trouble remembering this. And so she wants access to his patient portal account to help him remember to get to these visits. This would also include access to open notes, to the notes in his portal account. And that way she could sort of help monitor his care. Seems like a reasonable request. So you ask Donna to leave the room, that's your practice, so you can just talk to Paul alone and examine him. And when you do that, back the wrong way. When you do that, Paul tells you that he hasn't discussed any of his alcohol relapses or his depression diagnosis with Donna. He says, you know, it would be helpful, yeah, for her to have access to his basic medical information, including those lab appointments. That would be really helpful. And he admits that you know, he'd like that. But he doesn't want her prying into his business, into his medical affairs. He says that's none of her business. He gets sort of defensive about that. He doesn't want to have to talk to her about his depression. And he thinks that's sort of between him and you, him and his doctor. You were also referring him to an optometrist today. And he says, you know, by the way, like that optometrist, they don't have to see any information about my depression or my alcoholism or, you know, my alcohol relapse, do they? Which is a good question. So these are some of the questions that come up frequently for clinical providers, where we have to determine whether or not we can share data that would be helpful for sharing with another provider or another family member, but restrict data that the patient would like to keep personal or would like to keep between themselves and the provider, that they feel is sensitive or they feel is private, and that they don't want all data to go. They would just like some data to go. So I'm going to give another case example. This is Juliana. She's 16 years old. She comes in. She has a history of asthma. She comes in for her well child check. When you talk to her about her social history, she says she's sexually active with her boyfriend. They are using condoms most of the time. She doesn't have any complaints today. She's not having any signs of a sexually transmitted infection. She does request a prescription for an oral contraceptive pill. Now, in your state, like most states, when a teenager comes to you for reproductive health advice or reproductive health treatment, that is confidential information. So even though she's under 18 and she's a minor, and you would typically share most information with her parents, there are state laws that are typically very specific state by state as to when you can keep certain information from a patient's parents. And in this case, in your state, like many states, reproductive health issues tend to fall under those laws. And Juliana says, I don't want to talk to my parents about this. I am concerned, you know, that would be too hard of a conversation. They don't know about my boyfriend, and they don't know that we're sexually active. So you discuss the contraception options with her. You send the prescription for the oral contraceptive pill. You also send a urine test for gonorrhea and chlamydia, which are sexually transmitted infections that sometimes present without symptoms. The next day, you get the results back, and she is positive for chlamydia. She doesn't have gonorrhea, just chlamydia. Now, you know that Juliana wants you to discuss this only with her and not with her parents. So you got her cell phone ahead of time, and you call her on her cell phone with the results and the plan for an antibiotic for both her and her boyfriend. You treat both her as well as her boyfriend so that he doesn't reinfect her. When you prescribe the medication, the azithromycin, which is the antibiotic, you tie this to an ICD-10 code for chlamydia in your electronic health record, and you add that to her problem list. It's important for you to know that she has chlamydia that can have complications for her reproductive system down the line. So you put that in your electronic health record and you add it to the problem list. So Juliana has full access to her patient portal. As an adolescent, she can see the notes in her portal. She can see her diagnoses in her portal and read those. Now, her parents have also been using the portal as proxies to monitor her chronic disease, her medication management for her asthma, reminders for her allergy appointments. In your patient portal, her parents can look at her medication and problem lists. They come through to the portal as sort of a curated view of the electronic health record. Previously, before the 21st Century Cures Act went into effect, Results were released 5 days after they were finalized, and now they are released immediately according to the stipulations of the 21st Century Cures Act. So as soon as that chlamydia result is finalized, it goes into the portal. Your note also goes into the portal, unless you have restricted it in some way with EHR specific functionality to do that. Even if you have worked with your EHR vendor to restrict the release of results or the release of the note according to what's necessary per your state laws to protect this type of information, then the bill gets sent to the insurance company, and the insurance company sends the explanation of benefits to Juliana's parents, who are her guarantors. So it's hard to restrict all of this information. So we can see how much of a challenge this is. When we think about this at a high level, the sharing of this type of private healthcare information between providers, organizations, patients, and their families really can only be freely accomplished when we have some agreement around sort of the balance of patient privacy and the need for patient safety. At some point, sharing of information does require that balance. With Paul's case, right, there is this need for him to be able to safely get to his appointments, and we want to share that information with Donna, but also we have to balance his need for privacy. Right? And so we have to also come to some agreement on how do we identify sensitive data, how do we tag it, how can we protect it once it's tagged, how do we display the sensitive data or display that we are not showing the sensitive data, and then how do we share and reshare it. And we need to come to some agreement about that, because if I do it one way and someone else over here does it a different way, there's no sort of standards to sort of agree upon that, then we don't, then it's patients don't know what to expect, and providers don't know what to expect, and entities don't know what to expect, and no one can sort of determine whether data is sensitive or not if we don't know what to expect across this entire sort of complicated ecosystem. There are a number of relevant laws here. I think people are pretty familiar with some of the federal laws. HIPAA, which is used to protect privacy, but really is a law about sharing data for treatment, payment and operations, and making data available to patients as well, and enabling healthcare. It does have privacy protections as part of it. 42 CFR Part 2, which is a law around substance use disorder data, and specifically pertains to federally funded substance use disorder clinics. Constitutional law and the Fourth Amendment about protecting one's right to privacy. With adolescents, there's the Title 10 around reproductive health data, and FERPA around educational data and protecting those privacies. There's state law, as I mentioned, different state laws having sort of, especially around adolescents, different states have different laws around what data is protected and what may not be. And then there's international law, specifically GDPR, which protects all consumer data, not just healthcare data. So there are a number of laws to sort of take into consideration here. So when we think about what areas of the chart may be sensitive, one of the things that I really kind of want to drive home today is that sensitive data, the classification of sensitivity is entirely subjective. When we think about some of the areas where sensitive data is most likely to reside, in registration or the demographic fields, sexual orientation or gender identity data can be sensitive to some people. It may not be sensitive to some people. Some people may feel that it's almost offensive to consider that sensitive, right? That's their identity. But to others, that could be sensitive and something that they want to keep private. The consent to treat for a sensitive procedure. For instance, if someone has an abortion, that consent to treat could be considered sensitive. Patient level data like the problem list, the past medical history, the past social history, family history could be sensitive. the fact that someone was adopted could potentially be sensitive data, and if a family history is unknown. Medications or allergies could be sensitive. In Juliana's case, the oral contraceptive pill was sensitive. If she had an allergy to that medication, that could also be sensitive data, knowing that she was on the medication. Social history, like sexual partners, like alcohol use and substance use, could be sensitive. Increasingly, we're collecting data around social determinants for good reason, but that can also be sensitive. Housing insecurity, food insecurity, intimate partner violence can certainly be sensitive data. At the episode level, the visit note, certainly things that are free texted within the note, individual sections of the note or the whole note itself could be sensitive. Procedure documentations, documentation for a sensitive procedure. Screening questionnaires could be sensitive. And then diagnostic tests or results, as we've seen. So these are just some examples. There are many more. I think the difficult thing is that there are so many areas of the chart, and these are captured in very different ways from a data perspective. So some of the registration data may be vendor-specific, structured data. It may be unstructured data. It may be captured as a PDF, scanned into the chart. Right? Some of the problem list data may be captured as, in structured SNOMED or ICD-10 codes, RX norm codes for meds or allergies. But some of this, again, may be vendor-specific, structured and unstructured data. And so there's a wide breadth of data types that these encompass. The data flow is also very wide in its breadth. The data goes to many different places: ancillary services, labs, radiology, pharmacy, other providers, other healthcare organizations, the portal, as we've pointed out. It's printed in reports, less so now that people are using the portal more, but still in many cases we print things out for the patients, print out letters, and print various pieces of information, which may sort of have different functionality than the electronic version of those reports. You can go to third-party apps via an API. You can go to HIEs, you can go to the Department of Public Health. It can go to an ACO for quality purposes, or for research purposes, it can go to a research database. And then it goes to the payers. And as we saw, the issue can result in an explanation of benefits, going back to the patient or the guarantors. We mapped this out just for Juliana's case. So just to sort of show you what that looks like in terms of just the sheer complexity. And this is a swim lane diagram with each of the, and you can't read it, but on the left-hand side, each swim lane is a different actor in terms of kind of all of these places that the data is sent. So it's just incredibly complex. Then we need to think about how data access is controlled in any particular entity, right? So in an EHR, at any one of these ancillary sites, so we can control access at the individual level. We can control access for a specialty. We can control access at the role level. You can control access at the entity level. Not all systems have defined roles the same way or have the same defined roles. So if at my organization, I say, okay, all pediatric providers can access this data. Well, we may have defined pediatric providers one way, and at the organization down the street, they may have defined pediatric providers a different way. So we may not know what to expect if I say, all right, I'm going to limit this data to pediatric providers, and then we send it down the street, a different set of pediatric providers may be able to access the data. So there's discrepancy in that, and not a lot of definition on how that data access should be defined or delineated. So I think we've outlined a little bit about why this is such a challenge, right? There are many different stakeholders. There's a ton of different types and flow, and the flow of data is incredibly complex, both internally to an organization, as well as externally to other entities. There are questions of data ownership. Do I, as a patient, own my data? Can I determine exactly what happens to it? or does the entity that produced the data own that data? And I think, we are in a paradigm shift toward more patient ownership of their data. There still is some sort of dual ownership at this point. There's this question of access control definitions. There's the question of patient safety versus the right to individual privacy. So if I say I don't want my reproductive health data being shared, is that going to cause patient safety issues for the doctor who sees me tomorrow? Are they not going to be able to adequately diagnose me if I come in with abdominal pain and actually, right, I have an ectopic pregnancy, and they don't know that because they don't get to see my reproductive health data, right? And so, and at the same time, the other side of that equation, or the other side of that argument, is if we give that doctor some access to know that I'm withholding some data, if it says, there's some data here that you're not seeing, you should ask the patient about it. Does that does that interfere with my right to privacy? Right? Does that the privacy experts would say, even telling the physician on the other side that you're redacting or you're withholding data is a privacy violation. So there's sort of two concerns at odds with one another. And then the development and implementation of standards is incredibly complex. So this has basically led the industry to kind of wave the white flag and said, this is just too hard to do. We're going to kick the can down the road. We've got lots of things to worry about right now. We've got MIPS to worry about. We've got 21st century cures to worry about. We have way more on our plates than we can deal with. And this just kind of makes our heads spin. Too hard to do. Let's just not deal with it right now. It's too big to tackle. So here's basically what's happened. This is the current state. Even though the whole problem is too big to deal with, we've still had to comply with state privacy laws, as I've mentioned. And so patients who have sensitive data as defined by state privacy laws, or who really don't want to share their data because they have data that they feel is sensitive, have to choose whether to share all of their data or none of their data. Now, patients may not actually get to choose this. This may be done algorithmically. So an organization or a vendor may say, okay, we know that that adolescents have that state laws, many state laws say that we can't share reproductive health data for adolescents. And so we're just going to turn that off because there's no way to do this safely. And so, we're going to put all of the reproductive health labs and imaging studies and diagnoses into a list, and we're going to say any of those, if somebody has one of those, we're just not going to share it or not going to share the data for the patient at all. So patients can either choose, or sometimes it's done algorithmically. This can lead to some concern for data blocking, but even more concerning, I think, is that we're inadvertently producing healthcare disparities. So a patient that doesn't have any of this sensitive data, they get the full benefits of interoperability, all of the things that we're so excited about interoperability providing us. They have their PCP, and they have the data from their PCP's office about their medications, their allergies, their problems, all of their healthcare information. And then they end up in the ER. They have a car accident, they go to the ER. All of the data flows to the ER physician. That physician has all of the data needed to provide the optimal care for that patient. They know their medications, they know their allergies. If the patient's unconscious, doesn't matter. They can provide all the optimal care for the patient. Similarly, if there is someone helping that patient to manage their care using the patient portal, that proxy has all that data and can assist the patient with their health care. So that patient gets to leverage all of the benefits of interoperability. Now take a patient who has sensitive data. If that patient has to choose to share all or none of that data, and that patient has chosen not to share that data, or algorithmically it's been blocked, when that patient goes to the emergency room physician does not maybe have their medications, does not maybe have their allergies because the patient has substance use disorder or has a behavioral health condition or has something else that may or may not be related. But now, as pertaining to their medical condition, the physician doesn't have all of that information. So they don't get the same level of care as the patient who does not have sensitive data. Same thing with the portal, as we saw with Paul and Donna, right? If Paul doesn't want to share his data about his behavioral health condition with Donna, she doesn't get access to his portal. And so she can't help him and assist him with his care as she otherwise might. So we're producing disparities where those who have sensitive data don't get to leverage the benefits of interoperability in the same way that those without sensitive data do. So who's affected by this? When you say this is not many people, like most people are just fine just sharing their data. So who has potentially sensitive data in the classic form? Like, not everyone who has these types of conditions would consider them sensitive. In fact, we're trying very hard to destigmatize conditions like HIV, which should not be stigmatized, but have been, and many people still feel that that's sensitive data. So there are millions in the US who have HIV, who have another sexually transmitted infection, who have mental illness also, which should be destigmatized, but still is very sensitive to many people. Substance use disorder, who've had sexual violence or intimate partner violence, other intimate partner violence in their lifetime. This is many of us. This is not just the sort of edge cases out there. And as I mentioned before, sensitive may mean different things to different people. Something that's not sensitive to me or not sensitive to you may be sensitive. So, right, it may not be one of these conditions, but an NFL player having a knee injury may be very sensitive to them, right? That they don't want that getting out. And so it's very subjective. But there are many people affected, who this could make a difference too. There are certain populations who we know are more impacted. So medical mistrust has been higher in historically disenfranchised populations, many of whom are still disenfranchised. It's associated with decreased compliance with healthcare recommendations. So in people of color, African-American men with prostate cancer have reported lower levels of trust in the healthcare system. African-American women with a family history of breast cancer are less likely to get recommended BRCA testing. And this has been associated with medical mistrust as well. Black men who have sex with men have reported experiencing racial and sexual orientation stigma. And mistrust of medical establishments. And this stigma, importantly, the stigma and mistrust is associated with an increased gap since their last exam and their HIV care. So it's not only that there's medical mistrust, but this is driving people away from good healthcare. And so I think the hypothesis here that we're sort of going on is that if we can give choices to people, especially in populations with higher levels of medical mistrust, and in providing control over some of this data, that this can help increase trust in the healthcare establishment as a whole, and increased trust would then increase the adherence to these care recommendations and increase the health of populations. But that overall, this would play into improving levels of trust across these populations in general. So I think there's those on the call may have heard about some of the previous efforts to address this issue. For those who haven't heard about data segmentation for privacy, or DS4P, this is a standard that was developed first in 2011 as a CDA standard. It had sort of two criteria at that time, a send and a receive criterion, send criterion and a receive criterion. And it allowed tagging of the CDA metadata at the document level, the section level, or even down to the entry level, to say that the data there was restricted and subject to restrictions on redisclosure. Now, it was really developed for the 42 CFR Part 2 use case, meaning the law very specifically around federally funded substance use disorder centers. One of the pieces of that law had to do with redisclosure. So it was very focused on tagging a piece of data to say, hey, you can't redisclose this. It was successfully piloted by the VA and SAMHSA, Cerner, and NetShare. And there have been some developments. There's a version for HL7 version 2, and there's been a FHIR implementation guide that's now been developed. And the FHIR version is what we are focused on. The PP2PI group is focused on. But DS4P in general has been proposed and adopted by ONC as optional certification for MU3 and optional certification in 21st century cures for the pediatric certification and opiate use disorder prevention and treatment criteria. So the government has looked at this and said, hey, wouldn't this be great? Wouldn't it be great to be able to granularly tag data in this way? So I'll get back to this in a few moments about sort of why this hasn't taken off. But just to sort of go through it a little bit, this is how it works for the CDA standard. So a patient is receiving care at their local hospital, and they say, okay, I don't want this data shared. This is, you can share it with one other person, but you can't redisclose it. This is sensitive data. So you share it with the entity you're going to share it with, but it's tagged, and they say that, you know, the alcohol and the drugs are sensitive data. So when I share it with that one other entity, that entity can't share it further. And that's really very much that 42 CFR Part 2 use case. So that's sort of how it works. So the other thing that has come up over and over again in the notice of proposed rulemaking around 21st century cures and many of these discussions with the government is consent to share. So if you can tag data, how then do you determine where it goes, or, you know, who has control over it? So consent to share, C2S, is this open source tool that was developed by SAMHSA using a FHIR consent resource, but it really was around the data tagged that was using the DS4P CDA criteria. So it allows patients to make meaningful choices about how to share their sensitive data. So basically, you log in as a patient and you see this front end patient-facing user interface, and you say, okay, I want to share my reproductive health data with, you know, my PCP, my, you know, OBGYN, but not with my optometrist, right? And so you can consent to that. In order to do that, you know, we need a definition of what do we mean by reproductive health data? What do we mean by behavioral health data? What do we mean by, you know, substance use disorder data, and all of these sort of definitions. And as part of this, SAMHSA started developing some terminology value sets, which they stewarded for a while. They are hosted on VSAC, the Value Set Authority Center, but that NLM, National Library of Medicine, runs. But they are no longer stewarding those value sets. And they're very much focused around, again, substance use disorder. So the back end serves as an access control service. So it says, okay, the patient has said where it wants to go, and this back end integrates with the EHRs and HIEs, provides that policy configuration, and sends the data where it's supposed to go and enforces that policy. So that's great. There were these tools. This was piloted as well at several organizations, but why has this not taken off? So I'll tell you why we think adoption has lagged. The first is these standards and this, you know, C2S tool really have been very focused around one use case, which is, as I've mentioned, the substance use disorder use case, and really have not met a lot of the high priority clinical use cases. So when I, as a CMIO, am trying to prioritize work for my organization, I am hearing from our organizational leadership and our providers and our senior executive leadership team what we need to prioritize. This is a lot of work to put into, to implement and to put into a production system. And if it meets sort of one use case and doesn't meet sort of all of the other things that are really challenging our providers and challenging our clinicians and challenging our patients, it's not gonna be very high on my priority list. So it's great that a couple of sites have piloted this and it's done very well, but to get organizations to be able to really implement this, it needs to meet the actual real life challenges that people are having day to day. As I mentioned, the implementation isn't easily scalable across organizations. So if I define my access control one way and the organization across the street defines it a different way, and if I define reproductive health conditions one way and they define it a different way, it's really hard. One implementation right now is sort of one implementation. There's not sort of a national approach to implementations, including terminology value sets, including recommendations on access control. There's a lot of pushback about patient safety and usability, and these really haven't been addressed by the pilots. So if I say that our patients can determine, hey, don't share my behavioral health data, but share everything else. How do I surface that so my providers know that there's some data that's not being shared, that they need to get an additional consent? What happens with our clinical decision support algorithms? Do they still function? What happens with drug-drug interactions or drug allergy interactions? Do those still function? How do those work? And is there a break the glass functionality? What should happen in those instances? And if we decide that sort of site by site, that's going to take a whole lot of governance and just hours of people discussing in ethics committees to sort of sort that out. It's just a lot of work and a big headache, to be honest. And so it just falls below the line, as I mentioned before. And finally, there's been really no carrot or stick from CMS or ONC. There's no financial or regulatory stimulus to do this. When it was brought up in the 21st Century Cures NPRM, years of proposed rulemaking, one of the major EHR vendors sort of famously said that it was going to take 100,000 person hours on the vendor side to try to build this in and make this workable because the standards are still immature. And they're probably right. It is going to take a lot of work. And so without some type of stimulus, why would anyone do it other than we all know, it's sort of the right thing to do and we should do it, but we need some type of funding and stimulus to do it. So how is PP2PI, how are we approaching things differently? So first of all, we're building off the previous work. We're not starting from scratch. We are actually working with the HL7 security work group that has been working on DS4P FHIR. Their co-chair is the co-chair of our security, standards and terminology work group. We're working in conjunction and in alignment with them. We have first started by expanding the scope of the use cases to more sort of widely encountered situations to make this more applicable to everyday kind of clinical life. We have cross-industry stakeholder representation, as I've mentioned. One of our key deliverables is using the Delphi method to achieve consensus-driven implementation guidance around some of these really challenging areas that I've talked to you about. We're leveraging advanced technologies such as NLP as we think about a sandbox demonstration and moving forward in implementation. We know that you can't put this on the providers. You can't sort of just tag every single data element and put something in the UI to have the provider select, yes, the patient wants to share this. No, they don't want to share this. Yes, and every problem on the problem list needs to be tagged. Yes, no, yes, no, yes, no. You got to put this in the hands of the patients through a consent management platform, similar to consent to share, but expanded now using DS4P FHIR, where the patient can drive this. And when they indicate yes, I want to share this with this person, or no, I don't want to share this with this person, that would leverage a security labeling service to drive that, as opposed to adding something more to the workflow. So just in a little more detail, we have developed this nationally acceptable set of use cases. As I've talked about, a geriatric use case that's focused on behavioral health, an adolescent use case focused on reproductive health. We're working with the Gravity Project on an adult use case focused on social determinants, as well as a mother-infant use case that focuses on linked data. So infant data, maternal data in the infant's chart, which becomes a real issue if, for instance, the father has access to that data through the portal, or the infant now is on a longitudinal medical record until they're 18 and can see sensitive data about their mom, from that was pulled over from when they were a baby. So we're working on these cases. We're working on what types of data flow that are in scope and out of scope, portal proxy access, or EHR to portal access, EHR to EHR, EHR to HIE. We're looking at mobile app access through an API. Some areas that are out of scope right now, but in our parking lot for a next phase are sending data to social services agencies, like CBOs, that we recognize is incredibly important, but is on our sort of next set in our parking lot, in our next set of work. So once we have these use cases, the goal is to draft a minimal set of potentially sensitive data elements. And our standards and terminology group is in the process of doing that. We are then working with the HL7 security work group to analyze gaps in the current standards and potentially ballot for standards revision as needed. We have an implementation and usability work group, two different work groups, implementation and usability work groups that are looking at developing consensus-driven guidance through the Delphi method in the areas that I talked about. The standards and terminology work group is also looking for a steward to maintain and update the terminology value sets, those consent to share terminology value sets, so that we're all speaking the same language about this. This is our work group structure. So we see we have these various subgroups: the clinical group that's defining the cases, the usability, implementation, standards and terminology, and then we have some overarching subgroups: ethics, legal and policy, and the patient perspective that lend input to all of the work that's going on, because there are many ethical challenges. There are a lot of legal and policy implications, and we need legal and policy input to all of this work. And then we really need a patient perspective as well. We have a lot of industry experts, but this all ultimately affects the patient. So we have patient advocates informing all of this work as well. Backwards again. So last year, we really convened the group at, the plan was to convene the group at HIMSS. It was at virtual HIMSS that we sort of convened the group instead, and we have chartered the group, organized into subgroups, and developed deliverables, and have made some progress with the clinical use cases. The standards and terminology group have made some progress around developing a process toward and taking one of the use cases to develop a process toward identifying the data elements and looking for terminology value sets. So this is where we are right now with our use cases developed, working on that final social determinants use case with the Gravity Project. As the standards and terminology group builds a profile with the sensitive data elements, works on identifying a steward for the terminology value sets and updating these terminology value sets to fit the use cases, and starting the process of standards revision. Our usability and implementation work groups are focused right now on developing questions and a process for the Delphi method around some of these really challenging and controversial questions. I've mentioned they're building persona usability pieces and storyboarding these to build a basic prototype in order to move toward a sandbox implementation. And going into the next couple of years, our goal will be to do a real world demonstration in the next few years. So that's where we are at the moment with this. I'm looking forward to your questions. We do have a website which has a white paper on it, some more information, as well as how you can get connected. There's an interest form there. So I invite you to fill that out. And I'm looking forward to your questions.
All right, great. Thank you, Dr. Galvin. We do have a bunch of questions, but before we do that, are there regular meetings of that work group? Folks, I know you said that there's a way to sign up.
Yep, we meet the first.
Is there additional info?
Yeah, we meet the first Tuesday. The larger group meets the first Tuesday of the month from 11 a.m. to 12 p.m. Eastern time. And if you go to that website, I'm gonna actually put the website in the chat. There's a form so that you can be added to our distribution list and the invite for the large group. And there's the website. Also, if you fill out that interest form, it will ask you if you want to be added to any of the subgroups. They have various meetings and various meeting times, but we can get you connected with each of the chairs to add you to those.
Okay, great. Thank you so much. I just wanted to make sure that that was out there for anyone who was interested. So moving on to the questions that we got. You were warned that you would get a question about this. One of the issues that's been cropping up is interoperability is slowly improving, is difficulty getting independent second opinions. How do you see your work in data segmentation, privacy and consent, enabling the ability to exchange data as needed, both for the regulations and to advance the functionality on all sides, while still allowing for enough patient control to permit independent second opinions that are not affected by the judgments or notes from the original provider?
Well, that's a great question. So I think that hasn't sort of been in our use cases. I think but ultimately, if a patient wanted to get a second opinion, looking at this work down the line, if I understand the question correctly, it's to get a second opinion without sending over the data from the first provider.
Right.
Correct?
One of the current problems with second opinions is that you walk in, the provider, especially if it's in the same organization, the provider basically says, I don't need to talk to you. I looked at what the other provider thought. I think it makes sense. And you don't even have a conversation with them.
Yeah, that's a great question. It hasn't been in our specific use cases. So when we're looking at this from a data perspective, we're looking at, how do you not share sort of this part of my problem list, or this, how do I tag sort of data related to, behavioral health and not sort of share that with the provider. In that case, you bring up a really good point, because I might want to share data related to behavioral health, just not, that provider's one note, for instance, with the second opinion provider, right? That provider's conclusions in their note. So we hadn't modeled that in our use cases, but it may be something that we would want to add to sort of that. Like I said, we hadn't, there were some things out of scope, like sharing with social service agencies and things like that we're adding to a parking lot for sort of the next round. And that may be something that's a really good point to bring up that we may want to add, which is sharing an individual provider's sort of note or kind of medical decision-making thought process to try to get a provider to think independently.
Yeah, and actually there's sort of another take on that, because you made a comment that it's not possible or feasible to tag every piece of data, but actually in a case where it's come up where a provider has asked a patient to get a second opinion, they might go through all of the available data and decide exactly which tests and which things should go. So it's not even segmenting by, don't send this particular provider this information, but it might be, I want this new provider to see this test, these two lab results and this one note
Right.
and nothing else.
Exactly. It may be a way to to automate the sort of prospective sharing of data, right? To say, I want them, as opposed to having to go through and say, send this, send this, send this. It means they send everything related to,
right. But yeah, but there may already have been, that also obviously gets complicated by the fact that as the interoperability rules slowly trickle through and start going into place, a lot of data is just automatically going to be shared everywhere.
Right.
Do you see any any way to handle sort of, is there some way to do a post facto withdrawal of data or
that's really hard. That once the data is out there, the data is out there, right? I think that's the really challenging, and that's why some people are just turning off their data. They're saying, I don't want to share my data because I don't know where it's going, right? But you're right. Once the data is shared, you kind of can't pull that back. And when a transition of care summary is sent, or a summary of care record is sent with a referral, not that much data is sent, but right, it's a very sort of high level overview. But when we connect via the interoperability frameworks, all the notes are there, and so you have quite a lot of information about that person. And patients don't really know often what they're consenting to when they sign data sharing agreements or data sharing consents, right? When they first go and get care somewhere, right? That 10 years from now, when they go get care somewhere else, that their data is all going to be shared, right? People wouldn't expect that. And so you're absolutely right. I think a lot more data is being shared out there, and hopefully not being used for nefarious purposes, right? I think that that there's there are concerns, I think, on the provider side as well. Like, now I'm getting all this data. Am I going to be held accountable to all this data? What happens if something goes wrong? And there was some information trapped somewhere 100 pages ago in the data that I didn't get a chance to look through because I only had 20 minutes with the patient, right? Am I at medical legal risk because I had all of this data? I think there's a lot of concern on both sides about the level of data sharing that's happening.
Yep, no, that's a good point too. All right, so let's move. Thank you for that answer. Let's move on to the next question. In the first example that you gave towards the beginning of the presentation, excuse me, you talked about restrictions on what someone who has a power of attorney or a healthcare proxy or some of those types of documents and permissions can see. Doesn't having one of those documents give, in your example, the wife, but whoever it might be, the legal right to see all of those records? Isn't that part of the point of having those documents? How do you determine what someone with these types of directives can and cannot see if that's not the case?
That's a great question. So in my example with Paul and his wife, Donna, the nuance there was that she is his healthcare agent in waiting, which means that he has designated her as his healthcare agent, but meaning in the future, when he loses capacity, that she will be activated as his healthcare agent. So currently, he has capacity to make his own decisions. He hasn't been determined by a physician to be incapacitated. He is having some memory issues, but he's not incapacitated. So, we could have left that out. We actually are looking at that as in our use case about the sort of advanced care planning and healthcare agents. But at this time, even though he has a document saying that when I lose capacity, she will be the person to make my decisions. And at that time, I think you're right. She would then look into his record. So that brings up that question. But at this time, at the time of the case, that's not actually activated. So she doesn't actually have that right. But it's a great question because it may bring up all these questions in his mind. Well, what happens when if I do lose capacity, then she's going to see all of the, this information that I might not want her to see, right? So I think the presumption is that if someone is incapacitated, and I'm not a lawyer, so let me not speak as a lawyer, but I think as a clinician, my presumption is that if someone is incapacitated and someone else is making decisions on their behalf, that person can view the medical record, but I would always consult legal in that case as well.
Okay, great. Thank you for clarifying that.
Mhm.
Here is another question. Oops, sorry, I had one of them in here twice. That confused me for a second. All right, how are we making sure that patients are making informed choices about with whom their data can be shared such that it doesn't impair patient safety?
That's a great question. And that's one of the big challenges, right? Like, how does someone know as a patient that if I don't, I could think like, my orthopedist doesn't need to know about my behavioral health condition. Like, they shouldn't need to know that, but maybe they do, right? Maybe they need to know about, the fact that you're on an anti-anxiety med, because if they prescribe you a pain med, it can interact, right? And so how do you inform patients appropriately that, withholding data, what that can do? Maybe the orthopedist does know because need to know because, the behavioral health condition, it may be impacting, whatever sort of, orthopedic condition the person has. So I think it's, as we move from a sort of more paternalistic cultural milieu where we've said as physicians, look, I know what's best for you, patient. Like I know that I need to see this data, to this paradigm shift where patients say, no, it's my data. I want control of this data. There needs to be some educational process in there. And I think that's part of the challenge. That's why we have the professional societies at the table to say, hey, we think this is reasonable, this is not reasonable. We don't want to sort of go out there and say, yeah, just, let the patients kind of control all of this. There certainly needs to be a level of informed consent. And what's happened in the past is HHS or ONC has put out YouTube videos, around data sharing. And my vision, or what I would think of, is that there would be some, nationally sponsored videos that could be produced, things like that, that then each site could use if implementing something like this, because it's absolutely sort of the crux of the issue.
All right, great. Let's see.
Janice, before
Yes.
you ask the next question, let me just step in quickly and ask Lynn to post our poll, our poll, so that we're capturing as much input from people who are attending as possible. So for just a moment,
Okay.
please take a moment for folks on the line to complete the poll that you see on your screen. And this will, according to the little timer on it, only require another 15 or so seconds. So thank you everyone for participating in this poll. The results are looking good, I'm pleased to say.
Great. And then we'll have more questions after the poll.
And then we have more questions coming up, so don't go away. Okay, that's it. Thank you very much. We're showing the results of the poll, as you can see. Excellent. We appreciate that. And we will now continue with the questions.
Great. And actually, there's actually a follow-up comment on the answer that you just gave, which is someone says that as a former ER nurse, they're worried that people cannot always anticipate the information that may become critical in an emergency situation. And I will tag on, has there been any discussion of temporary overrides for emergency only where the data gets dumped or something like that?
Yeah, absolutely. So break the glass or sort of a temporary override is certainly part of this. It's part of those deliverables that we're thinking about and part of that implementation guidance, right? So that's an open question. Should there be a break the glass, right? If I say I don't want to share my behavioral health data and then I come in unconscious to the emergency room, how are you as an emergency room nurse going to know, like, do I have a history of overdoses or, and so I think that is incredibly important. And that, again, is why we have the professional societies at the table, to be able to speak to, as well as a number of clinicians and ethics experts, right? So you're not getting my opinion, you're not getting an individual's opinion, and one clinician, one informatics leader's opinion on this, but this can really be developed as policy across professional societies to say, this is what we think is reasonable, and this is what we think is safe care. The fact is, right now, we're not providing safe care to a lot of patients because they're either just not going into the emergency room, if they are worried about their data. I have patients who say, I won't go into the emergency room because they've tagged me as a substance user before, so I'm just not going in. And so it becomes an issue. Or we're just blocking all data completely, and so people don't get data. And so I think that's the balance that we're trying to strike here. But I think that it's really important that we are able to provide safe care. I as a clinician want data to enable me to perform safe care, and so that's why we're trying to do this, and to make thoughtful and educated recommendations with the right people speaking to this. So I absolutely hear you.
Okay, great. So we actually have two related questions, so I'm going to combine them. Do you see a process for standardizing the data categories available for this more broad category-based data segmentation, or do you see moving to a more granular decision-based about specific data or some other solution? And then the second part specifically, the second question specifically asks about using a formal reference data set, such as having RxNorm or SNOMED tags that get used for that purpose.
Yeah, that's a good question. So they're both good questions. So I think that at least to start, we will have to have some type of terminology hierarchy, right? So it's so that you are not saying so that people will have to sort of speak to, I don't want my STI data shared, or I don't want, my, it will be hard to sort of say, I just don't want my data on my bipolar illness shared, but, you can share the rest of my behavioral health data, right? Like you could share my anxiety data or whatever, right? But just not the bipolar. Like if you get down to that level of granularity, I think we get, it's a little harder. I think we have been thinking about it sort of rolling up to categories and standardizing those categories. In terms of a sort of an additional sort of standard or a like a category standard, or a not a messaging standard, but a terminology standard. You're sort of thinking about like RxNorm. I don't think we're thinking about an additional one. I think we are thinking about how we could map a terminology value set to the appropriate terminology standards that are out there. SNOMED, RxNorm, ICD-10, right, that are already out there. But additionally, this isn't going to work if there's not some tagging of free text as well. So our goal would also be to leverage NLP, because if you can tag all the structured data, you've only sort of hit like a third of the battle, right? Like it really has to do with free text notes as well. So I hope I answered those.
Yeah, I do. So if a follow-up question from me, if you are starting to look at natural language processing or other machine learning, what level of oversight do you see to ensure, one, that it's doing what you think it's doing and applied properly, that it's applied without bias, all of the issues that we're starting to see as people ramp up more and more machine learning, the fact that they don't understand that it's probabilistic rather than an exact science? Could you address some of those questions, some of those areas?
Yeah. So people who are smarter than me, we'll do it. I guess I would say we are not going to it is not one of our deliverables to develop our own NLP engine. We would be working with other vendors and other sort of experts in NLP to do this. Ideally, some who are already on the market and well established. So it's, yeah, we're not in the business of trying to create a new NLP solution. But we want to work with and vet some of those that are already being used in clinical situations and have already sort of looked at bias, looked at probabilistic outcomes, and so, yeah.
Okay, great. All right, so the next question, GDPR has a right to be forgiven requirement that enables an individual to have their data held by a particular service provider deleted. Obviously, that's European and not the US, but do you see considering, I mean, we talked about this in the emergency situation. This is sort of what we were talking about before, but do you see this being considered for certain types of data sharing that might be useful in the short term? And will this be considered as a potential future capability? So do you want to comment more generally than what we already said, maybe?
Yeah, no, it's a good question. The right to be forgotten from GDPR. So the California, the CCPA, the California Consumer Protection Act, is modeled very much on GDPR, and I'm trying to remember. I think they have something similar to the right to be forgotten stipulation, but it really pertains to consumer data, and I believe that healthcare data is excluded from that. Again, I'm not a lawyer, so you'll have to forgive me there. I don't think we have seen anything like the right to be forgotten from a policy perspective in terms of our healthcare data. I think there are some rules around how long health information management has to actually keep our data. I think it's like 7 years, and so I think that there are bigger concerns about data loss from a healthcare perspective, right? Somebody needs the data and we don't have it. I think it's a great question because people do potentially want and especially now with longitudinal medical records, people do want their data forgotten, right? Or they do want at least the ability to change, right? Like take somebody who's 50 now, who, in their 20s or when they were 16, had an alcohol overdose, right? And that's in their medical record forever, right? If they, come into the emergency room and they've never been to that emergency room before, or they've been in that emergency room once before when they were 16, the last ER visit that comes up on the screen is for this alcohol overdose. And immediately a clinician's perspective is, skewed sort of one way or the other, right? And so based on that. And so I totally understand that. And at the same time, these are questions that we talk about in the PP2PI group. Like, at the same time, maybe they still do have an alcohol problem. So if they didn't have an alcohol problem, maybe I wouldn't want to see that data and wouldn't want it to bias me. And if they do have an alcohol problem, maybe it's important for me to know that they've had a history since they were 16, and so it's really difficult to sort of know what to do here. There's not sort of a clear-cut answer, but that's sort of a long-winded way to say it's complicated, and I haven't heard of anything like the right to be forgotten coming into the healthcare space at this point from a policy perspective.
Okay, great. So a couple more questions, and if anyone has any last-minute stuff, send them now. But we're not seeing very much sharing yet of provider data outside of things like care quality type services that are governed by EHR vendors. Do you think that providers are holding back on the data sharing requirements and the interoperability federal rules until they're absolutely required to do it, or do you see something else happening?
So I don't think people are holding back. I mean, I think that looking at my own organization, we're sharing through the HIE, we're sharing through care quality. I think that it's complicated to set up sharing because because of all of these issues, right? Especially consent issues can be complicated. And so in areas where it's not required, it can just be, right, a project that's on somebody's list, right, and has to be prioritized. But I don't know that people are sort of holding back. I think it's a matter of just sort of prioritization in terms of kind of the various different ways that data is shared. Like, for instance, sharing with the SSA and the DoD, right? That's sort of a separate build with separate consents that, you know, takes some work to do. Yeah, I haven't seen that people are actually, in my experience, I haven't seen that people are holding back as much as it just takes work to sort of build it out if it's not already native to the EHR vendor, and if it's not already, you know, if you don't already have that interface with an HIE. There is, of course, there are still MIPS measures around transition of care, around reconciliation of information. So that is certainly driving people to want to share data, at least to, you know, the extent that they're concerned about those measures. But,
Great. So here's a really great question. How are you tackling the challenge of free text notes in relation to the classes of protected information?
in terms of, I'm sorry, can you repeat the last part?
The classes of protected information.
Yeah.
So I would take that either as the mandated to be protected or things that people have marked as please don't share.
Yeah. So that's where we want to look at NLP and NLP vendors, right? And so we haven't gotten there yet, but that's on the roadmap, and part of the thought process is that this can't just be tagged to structured data. There needs to be some NLP involved to address free text notes as well. Now, all of that said, even if we have an NLP solution, even if we're taking free text notes, I think one of the pieces of informed consent to patients is that I don't expect that we're going to get to 100% here, right? If I, as a patient, say, don't share my behavioral health information, this is just too complicated. There are too many tentacles in the chart. There's too many areas of data for me to feel confident to say, okay, yes, we can develop some type of solution that will get to 100% of anything related to behavioral health information in the chart. Because look at how many things can be related to behavioral health, right? I mean, and no NLP solution even, you know, could get to sort of 100%. And something could be in, you know, some part of the chart that you know, there's clinical nuance there that we may not think of as, you know, related to behavioral health. And so I think that's also a really important point for informed consent, is for patients to know that we may not get to 100% level of data segmentation and level of privacy protection as well.
So do you see what type of consequences or changes do you see when some of those slips start happening? I mean, some of the rules are legal, as you mentioned. Some of them are not legal, what may have a really big impact on a person's life. So what do you see, like the first time, or maybe not the first time, but the fifth time or the 50th time that someone starts screaming publicly about data that got shared when they said it wasn't allowed to be, you know, how do you see that sort of playing out? Are there other things you think that we can do to make that better?
Yeah, I mean, I think like any tool, like a tool can be trained over time, right? And so if we're using an AI type tool, it will get trained and get better. But certainly, I mean, I don't want to sort of paint a rosy picture that I think that any tool, data in the chart is incredibly complex. And even a sophisticated sort of AI algorithm is not going to be able to extract 100% of the data from the chart. And just because it's nuanced, right? I mean, you know, think about, it's just, a lot of NLP algorithms are trained for that, right? They understand the difference between a heart attack and like an assault, an attack like that, right? But those are hard and they need to be trained. And so I think there's, yeah, it of course would be hard for a patient from a trust perspective to know that some of that data was still transmitted. I think that needs to be part of the education and informed consent process. I certainly couldn't say at this point, like, sort of what level of accuracy any subsequent tool could reach.
Right.
And it probably depends on sort of the EHR itself, right, and how data is being captured.
Great. Thank you so much. I will pass back over to Denny for any final words, or Dr. Galvin, if you have any last words as well, feel free.
Thank you, Janice. Dr. Galvin, are there any closing thoughts that you'd like to share with us before we adjourn for the day? This has been a fascinating presentation. It's a very daunting challenge, and I think you've made huge strides in dealing with a universe of data and definitions and meaning and personalization that we're only beginning to scratch the surface of. But any parting comments or thoughts that you have before we adjourn?
Thanks, Denny. Yeah, thank you for having me today. It's really been a pleasure to be here and talk with you. It is a daunting challenge. It is, right, when we tackle even any of these questions that we're talking about, and just sort of spent some time going through, you can think about this and say, it's too hard. It's too hard to get to every aspect of the medical record. So why even do it? And I think what I'm here to champion and to continue to bring the group together, the PP2PI work group together to do is to say it's still worth it to try. It's still worth it, because if we don't try, we're ending up with worsening disparities. We're ending up with patients with medical mistrust that's unaddressed. And we likely are not going to get to, a perfect solution, a perfect, a utopia. But we're not at a utopia with anything when it comes to health data. And so how can we get to the best level that we can get, provide and continue to iterate, continue to work on it, and provide the best care that we can provide our patients, but not just sort of give up and say, that's too hard. That's too hard of a challenge. So let's not address it, and just, too bad for those who, are stuck with the disparity. And so that's where, we're trying to continue to organize and work with the right stakeholders, and we're excited about how far we've come and where we have to go. I think it's we're very much aligned at this point with the national efforts and ONC around this, and I think there's a real appetite for it, especially after the 21st Century Cures information blocking rules have gone live. People are seeing this now in their day-to-day practice, where they are saying, I really don't want to share this data with a patient, or with a family member. There's potential harm here, and so it's really a part of everyone's everyday life now, or a lot of people's everyday life now. So we're really excited, and we're really excited to have anyone on this call join us. Please do visit our website and fill out the interest form if you would like to be part of this work.
Well, we certainly would like to be part of it. We commend you for what you're doing. We appreciate especially the fact that there is such a strong focus on those who are disadvantaged and for whom the lack of this kind of control, or at least a reasonable approximation of it as we move forward. This is a journey. The destination is blurry, but the journey is a good one. I think that's a good, sort of North Star for keeping the effort moving forward and doing it with those who are, who will benefit the most. Maybe not everybody at the beginning, but perhaps those who need it the most first. But this is fascinating. I want to thank you again for joining us today. This was a very well received presentation. We thank our audience for joining us today. We are right at the bottom of the hour. Anna Galvin, thank you again for presenting. Audience members and members of the consortium, thank you for joining us today. And we're adjourned. Everybody take care. Bye-bye.